Good morning to our CCC Live Structural Heart Transcatheter Intervention in collaboration with Fuwai Hospital uh, structural cases, which will be shown today. And we have an excellent team from both sides, from Fuwai Hospital, China, and Mount Sinai Medical Center. So the way it will run, first we'll show one case, which was done as a case in box from Fuwai Hospital, and Professor Pen Zaibin, who is the vice president of the Fuwai Hospital, is one of our key moderator, along with the other team members, which he will introduce and show a case of TEER, which is transcatheter S2S repair for severe mitral regurgitation in appropriately indicated patient. That will go on for about 50 minutes with the presentation and discussion. And then in about, this is start at 8 o'clock, and then by 8:50, we'll end this presentation. Then 9 o'clock, we'll start a live case of catheter tricuspid valve replacement, which is TTVR. Patient has a prior tricuspid valve surgery before and now presented with severe tricuspid valve degeneration. And that case will be live shown by Mount Sinai Cardiac Cath Lab. With that note, I will just hand over to Dr. Pan Xiangbin to continue a presentation from their side and teach us about this very interesting TEER case.
Hello, Dr. Sharma. Let's start the case presentation.
Sure.
This is,
Yes.
Shall we go on? This is a 70 years old male. She had a transapical artificial cordy implantation 2 years ago. Right now, the mitral regurgitation is 4+ grade, and the regurgitation is mainly located in A2, P2 area and partially in P1 area. And VC is 7.6 millimeters, and EROA is 1.1 centimeters square. And the orifice of the mitral valve is 4.5 centimeters square. LVED 51 millimeters, and the LVEF is 66%, and LA is 58 millimeters. First, let me show you the transapical artificial cordy implantation. This is a Chinese-made device. 这个 ，OK， 没事。那对方看到没有？ Okay. Hello, can you see the screen? This is a X-plane view, and the left is back home view, and the right is is a LVOT view. And so we can see because the artificial cordy implantation, there is a plaget on the post leaflet. So from this view, from the back-com view, we can see the so we can figure out the plaget.
And this is done surgically, right?
Hello, can you see the echo?
Yeah, yeah, we can see that. Yes.
Okay, okay. So we know we have done the artificial cordy implantation 2 years ago, but right now we found the cordy ruptured, and 2 years ago we used the Chinese-made device MicroStitch to the transapical artificial cordy implantation, and we did edge-to-edge repair use this artificial cordy. But today we found that because of the rupture of the cordy, there is a huge mitral regurgitation. And from this view, we can figure out the plaget, the gasket on the leaflet, and also we can figure out the ruptured cordy. This 3D emphasis view. So we can figure out the nearly the P2 and the P1, there is a posterior prolapse, and also the A2 prolapse.
Yeah.
And the main challenge of this operation was that the previous artificial cordy has broken, but the gasket is still on the leaflet and is relatively stiff and lacks mobility. So from this true view, we can figure out the remaining gasket from previous operation here. I think this is a gasket left on the posterior leaflet. And the prolapse gap is about 7 millimeters. And the prolapse width is about 16 millimeters. And this is a pulmonary venous reflux. Then, let me show you the recorded case video. Hello, can you see the video?
Yep, very well.
Yeah, and then we make an X-plane view. The left is a BICOM view and the right is LVOT view. And we sweep from medial to lateral.
Right.
And so this is color. This is a grade 4 MR,
yep.
And mainly in the P2 and the P1 area. And also we can figure out the broken artificial cordy, and also on the posterior leaflet we can figure out the gasket, the plaget also. This is 3D emphasis view. Yeah, this is a prolapse area. So this is severely regurgitation. So our strategy, the first, we think about using the convergence strategy. So we think we make a clip in the P2 area, and then medial side to the medial to the prolapse area, the second one. And then we, according to the regurgitation, then we will decide if we need to deploy the third clip. And then we are going to deploy the first clip in the P2 area, P2A2. Here we measure the length of the posterior and anterior leaflet. So here we can see we can figure out there is a gasket or pledget on the posterior leaflet, and also the broken artificial cordy. Here we measure the pre-procedure mitral valve gradient. Our strategy is to do the mitral clip case procedure with pure echo-guided technique. Our team, Dr. Pan lead our team. 2 years ago, we started to do the mitral clip with non-fluoroscopic technique with pure echo-guided. And until now, in China, it has been finished 1,000 cases of mitral clip, and including that, 300 cases were finished by a pure echo-guided technique.
Wow. But no fluoroscopy. I know we use a little bit, but clearly that some fluoroscopy we still need. But you are saying that you have done a cases without fluoroscopy at all.
Yes,
yeah, you are right. We only use echo. We use echo to take the place of fluoroscopy completely, because we have many patients suffering from cancer. The patient have lung cancer, so we cannot use fluoroscopy for those patients. And not only for heart valve disease, also for congenital heart disease, we use echo guide procedure for more than 10 years. Yeah, many disease, ASD, VSD, PDA, including pulmonary valve, aortic valve, including coarctation implant stent, and appendage occlusion. We only use echo, totally only use echo, and can protect not only patient but also doctors. So now we are preparing to puncture the septum, which to help our echo is very clear to find the puncture site. So we also have some technique to make sure you insert the catheter according to the working length. It will be made the procedure safer because we don't use X-ray, totally only use echo. So Dr. Xie is advancing the wire, and echo can show us the wire past the IVC and going up to the SVC.
So actually, I wanted to interrupt one. Our expert, the surgical director of structural heart, Dr. Gilbert Tang, has joined, and he actually, Gilbert, they're showing a case where they put an artificial chordae transapically, and now the chordae have ruptured, and this is the case of TF. And Gilbert, you can unmute. Maybe we can show the previous. I know we have gone forward. This is the recorded case, and they say that all cases they do, or quite a bit, just by fluoroscope, by echo guidance, and no fluoroscopy at all, zero.
Hello, hello. Hi,
Hi,
你好。
Here, yeah, I see you.
他来了。Hello, Dr. Tang and Dr. Sharma. Then we go on.
Yes.
Yes, this the left is back cable view and the right is short axis view. And here we are checking the puncture site.
Yeah.
Right now, the catheter is in a ovalis fossa. Yeah, fossa ovalis. Yeah, and we choose the posterior and maybe a little bit inferior. So here is here is the tenting. And then we measure the puncture site, the length from the puncture site to the mitral valve annulus. So it's about it's more than 4 centimeters. And this is 4.3 centimeters, the puncture height. And then we did puncture. So from the screen, you can see we don't use the DSA device. So right now the wire is in the left atrium, and we advance the wire into the pulmonary vein, and then we exchange it with the London Quest valve. And now this is the SGC advanced following the London Quest wire. Here, the SGC is coming and cross the septum. Now you can see the SGC is in the left atrium. Then we adjust the mitral clip to do the steering to the mitral annulus. we adjust the M naught. Here, this is the warfarin bridge. If you have any comments, please ask us.
Yeah, so great case so far, very nice imaging. So we typically don't use the Lundquist except for TMVR replacement because we worry about left atrial injury. So we typically use Safari wire. What are your thoughts on the wire choice?
So we use Lundquist because sometimes if we cannot advance the wire into the pulmonary vein, so we can use the Lundquist and to pre-remodel the tip of the Lundquist to make 3 circles. And so the top of the Lundquist do not need to go into the pulmonary vein, just in the RA is okay. And we can also do to advance the SGC into the left atrium.
Okay, I see. 明白. Thank you.
Thank you. Let's go on. Here, the clip is near the mitral annulus. A 3D view, we do the orientation. So Dr. Sharma, Dr. Tang, you can figure out we are aiming at the prolapse area, and our strategy is to do the first clip, medial to the prolapse area. This is the first one. So almost in the P2 area.
Yeah, I agree. I think we typically look at the width of the prolapse and decide how many clips to implant, number 1, and number 2, where to implant. So you can see that there is the first area, a little bit more medial, as you mentioned.
Yes, because this is the first case we do the mitral clip for the artificial cordy broken case. So we concerned about the gasket on the posterior leaflet. We are not sure about if we clip the plaget. We concern about the stability. So first we do the first clip medial to the plaget area. So here, this is the orientation. It's a 12 o'clock. Just the medial to the prolapsed posterior leaflet. Very close to the prolapsed area. And we use this view to the trajectory. Then we advance the clip into the left ventricle. We open the clamp, the clip. Ready to do the grasping. . . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 . 。 。 . 。 . 。 。 . 。 。 。 . 。 。 。 。 。 。 。 。 。 。 。 。 。 。 。 . 。 。 . 。 。 . 。 . 。
I think it's important for the audience to know. You can see how you have an excellent bicombinatorial view to the grasping view. So your apex is at 6 o'clock on your echo. And also you can see your clip trajectory is excellent. So in the atrium, initially looks a little bit more aorta hugger, but now you corrected it. So when you come to grasp, it's a perfect alignment with the leaflet coaptation plane. So it makes the grasping much easier, as you have shown nicely here.
Yes, yes, we did. We use the plus knot to do the counter aorta hug action. Yeah.
Yeah, this is great. So this is for, you're an expert mitral clip center, but for people who don't do many cases or not familiar, it's very important to show that what you did with the plus knob and anterior guide talk to optimize the trajectory like you see here. It's very nice graph. You can see that right there.
And right now we check the orientation again. And we do the grip down the first time.
Yeah, just one small comment here. It's very important, as you shown here, that you lower the gripper slowly. I think sometimes people are very nervous and drop the grippers very quick. And the imager may not be able to save the image, the recording of the dropping the gripper. So you might not know how much you insert. So when we teach our trainees, we tell them to drop it slowly so the imager can save the image like you have done here. Very nice.
Thank you. Usually we will tell the echo doctors we will grip down and he will prepare to record this action because he will measure the length of the grip down, the leaflet.
That's exactly right. Yeah, thank you for pointing that out to the audience.
And the first grip down, and we are not sure, we are not so satisfied with the grasping, and we check the tissue bridge, we are not satisfied, so we plan to do the second.
Yeah, I think it's a good grasp. I think some people may say you want to optimize the posterior to avoid the SLDA, but it looks like the prolapse posterior P2 is quite long. So sometimes you try to go posterior to get more of the P2, it might not be possible, but it looks like you had a very good grasp already. So in the previous image. But you can get more posterior if you want to reduce the what I call the elbowing effect of the prolapse. So if you grab here, you might still have a little bit of a posterior lift. So if you can get more, you can reduce that. This is what we do in surgery, where we really increase the coaptation plane by reducing the prolapse. So the clip try to do the same thing, but of course you only have a fixed length. So it would be better when we try to do grasping to grasp as much posterior as possible with the prolapse.
Yes, the first try, we did not so sure about the bouncing of the posterior leaflet, and then we tried twice. And also we moved the clip a little bit to the a little bit to lateral, so very close to the prolapsed area. And then we prepared to do the second grip down. Yes, grip down. Yeah. So we are so sure about the bouncing.
Yeah, I agree with you. This is probably a better grasp. You can see you all the way to the posterior annulus. So you're getting all the posterior leaflet in there, and you see a nice bounce on both grippers. So yes, that is very important to make sure that you have the leaflet pinned between the gripper and the clip arm rather than the leaflet above the gripper. So we had a case yesterday where it was above and we had to free it up to be able to confirm that the gripper can be dropped successfully. So very nice. And you can see you're closing the clip now.
Yes.
So it's very important, I think, also for the audience to know, and I'm sure you're doing this during the case, that when you are closing, you need to go a little bit more posterior and relieve the tension by advancing the clip a little forward to maintain the insertion. So I see that you're doing that there, but I think the audience needs to know as well, because these movements are subtle, so it's not that easy to appreciate in a case like this.
Now we measured the gradient is about 2.
I have one question. Do you do the invasive hemodynamic monitoring with the G4 because to look at the left atrial pressure change?
Excuse me, we only have the G3 system.
I see.
And also, thank you for your comments. We did measure the LAP. Pre-procedure is about the mean LAP is about 14 milligram.
So that's a good point. So the G3 system, when we used it, we also connect the pressure tracing, and actually you can get some tracing. Sometime it might be dampened, so it might not be reliable, but we actually publish a paper on using G3 on measuring the left atrial pressure. So that is actually possible. So you can try it next time.
Thank you. And now we release the first clip.
So again, I think from a teaching point, since you do not have use fluoro, because it's echo guided, when you release the pin, the imager, the echo imager needs to show you where the pin is being pulled back into the guide to avoid left atrial, any kind of potential injury. So it's very important to do that because in fluoro, if you have fluoro, you can see it very easily. But if you only have echo, it's very important to teach the audience about that.
Yes. Our echo doctors was very familiar with this procedure. So we make sure the full release. And then we advance the second one. And the second one, we are thinking of to clip directly to the prolapse area. So we will clip the plagate and the leaflet both inside.
Yeah, I agree with you. I would do the same, and I would clip right next to your existing clip. And in an ideal situation, both clips will be looking exactly parallel to each other. Since you have the good orientation on the first one. And
Here
once you
we
have
are-
G4, I think you'll be even happier with the procedure time and efficiency because it really helps you with the independent grasping, especially in more difficult anatomies.
Yes, there are several Chinese-made clip device similar to the G4 they are on the clinical trial in China.
So here you illustrate this very nicely. For the second clip, at least in our center, we're always going closed, not open, so so that you avoid getting stuck to the leaflet with the gripper arm. So do you do that routinely with the second clip?
So we just according to the explain to make sure the second one do not interfere with the first one. And also the 3D view.
Yeah, 因为第二个 clip 我们通常都是关起来进去一个 left ventricle 啊，那就没有一个 interaction 跟一个 first clip。
Yes. Here we do the orientation.
So one advantage with fluoro is that if you put the second clip and your first clip is good orientation, then we don't use the 3D. We just use the fluoro to make sure no parallax with the first clip and with the second clip. So we just use fluoro to actually go in and enter, and we try to do as close as possible. So that's one difference that you can use with fluoro guided rather than echo guided. But I agree with you that with echo guided only, you need to use the 3D here to confirm the orientation.
Yes, yes. So right now we use this view to make sure the second one is close to the first one, and right now we confirm that the second one aim directly to the prolapsed area. Maybe it seems the second one is not so close to the first one, but it directly to the prolapsed area.
Yeah, you can also use the 2D like you saw already in the bicommissure view to check the distance between the two clips as well. So that's another method.
Yes. And then we do the second grasping. So here you can see figure out clearly the plagate on the posterior leaflet.
Yes.
So here the bouncing is very clearly. Yeah, that's a bouncing. Clearly.
Yeah, it's a very nice bounce. You get good insertion of both leaflets. And looks like you're about to close the clip now.
Yes. And we release the tension. and then we check the color, to check the regurgitation.
Yeah, I mean, looks like there's almost no MR.
A little.
But
A
yes,
trace.
maybe just a little bit there, but it's a
A
very
trace.
broad prolapse. So, I think with G3, this is an excellent result. I think with G4, you can consider using the wider clip to start. And then if you need to, we typically add an XT afterwards. So you increase the width of the coaptation and to reduce the MR even further.
And then we plan to release the clip.
Did you do a gradient measurement here again?
Yes, yes. And these two clip are it looks like stable, looks like stable.
Yeah, no, it's very stable. I'm just curious how much the gradient increased with the second clip. Probably I would say 3 to 4.
Yeah, we are checking the gradient.
And what
It's
is your
for-
cutoff now? I mean, we know that we want to be less than 6 or 7, but what is the cutoff from so that for the audience that where we will not release the clip if the gradient goes to what number?
So usually 5 for DMR case.
Okay.
That's a cutoff point.
Yeah, same for us for DMR, and there's been literature showing that for DMR needs to be 5 or less, but the secondary MR may be a little higher if necessary.
Okay, so it's 3 or 4. Okay,
Yeah.
so we stopped. Yeah. Thank you. And thank you for your comments.
Very nice. Congratulations. 恭喜恭喜.
Beautiful case. All right, so we very nice demonstration, and hopefully next time we'll have a live demonstration from Fuai Hospital also. All want to see in action, and so basically we'll get ready now in about 10 minutes for a case from Mount Sinai, which is a very unique tricuspid valve degeneration with a TMVR using SAPIEN valve. All right, so we'll join in about few minutes. We'll get you back.
OK，
Thank
待会
you.
见啊。好，谢谢。
Bye bye.
Good morning from all around the world, and welcome to Structural Heart Life Cases, broadcasting directly from the Mount Sinai Hospital in New York City. I'm Pedro Moreno, I'm an interventional cardiologist, and I will be your moderator from the western part of the world today, because from the eastern part, we have another moderator from China, Professor Pang Xianban. He's a fellow of the American College of Cardiology. He's a member of the Chinese Academy of Science and director of the Structural Heart Disease Center. We'd love to hear from you, so please send us all your questions either through email, to the website, or through YouTube. Remember, you can view all the previous structural heart cases at www.ccclivecases.org. We have a great case for you today, and let me take you to the cath lab at Mount Sinai Hospital.
All right, good morning, Pedro, and of course, Dr. Professor Xiang Ben. We are just there about earlier case. And welcome to all from Mount Sinai Cath Lab for our this structural case session. Myself, Dr. Samin Sharma, Dr. Gilbert Tang, Dr. Kini, Sahil Khera, and our fellow Dr. Supawat and Richard. So we actually have now 4 structural interventional fellows. So program is growing quite a bit. And this is actually the second case which we have done since we started our structural live cases, is the tricuspid valve intervention. So we also did last time also the tricuspid valve replacement, TTVR, and similar case which will be showing it today. So with that note, knowing there will be a lot to show and discuss, we can start our presentation. These are our supporters for the case. These are all faculty, which I have mentioned, all of us, and Dr. Stem Larakas, he's on the echo side there, and you'll be hearing him quite a bit. And our cardiac anesthesiologist is Dr. Mark Stone, and our moderator from China is Professor Pan Xiangbin, and along with the few other associates are there, and he is the vice president of the Fuai Hospital. So this patient, we're going to show you valve-in-valve TTVR with a 26 millimeter Sapien 3 Resilia valve because of the patient age in a high-risk patient, because patient has 2+ heart surgeries. So with that note, this is the case. Our number 54 is a 42-year-old patient presented with dyspnea and ascites. And as we know, tricuspid valve disease many times present with, of course, edema and ascites. Patient had a first surgery at age of 17 in 1998. Then has a few complications as shown there, and then had a surgical tricuspid valve replacement with a 27 millimeter EPIC porcine valve in 2021. 2021, yep. And then has a pacemaker, AFib cirrhosis, and esophageal varices. A lot of medications, and as you see, warfarin in most of the cases. With the tricuspid valve, they end up with getting some kind of anticoagulation, TTVR particularly, on, and patient's good medical therapy. Rest of the parameters are shown here. And patient has a echo, which has been done as a TEE. Severe bioprosthetic, tricuspid valve stenosis and regurgitation with a mean tricuspid gradient of 10, and pressure half time 331 millisecond, and effective orifice area of 0.6 centimeter with a severe bilateral atrial enlargement, and ejection fraction is good. So more importantly, we should show the live TE echo in this particular case by Dr. Larakas.
Yes. Yes, good morning. Sorry for this. One minute here. Okay, sorry for this. So this is a 4-chamber view. As you can see, the LV function is almost normal. As Dr. Sharma said, the RV is like moderate dilated with mild decreased function. Both atria are very dilated. You can see the smoke in the left atrium. And also you can see the interatrial septum bulging to the left because of the high right-sided pressures. As Dr. Sharma said, the patient has metallic mitral prosthesis. As you can see here, the valve is functioning well with minimal normal MR at the hinge points. The mean gradient through the mitral valve is 3 millimeters mercury. This is a 3D image of the mitral valve. You can see the two discs and no significant mitral regurgitation, no PVL. There is smoke in the left lateral appendage, but no clot is seen. This is the pulmonic valve functioning well, no problems. The aortic valve in the middle also functioning well, no stenosis, no regurgitation. And this is now the RVOT inflow view. As you can see, the tricuspid prosthesis, the leaflets are thickened, and in some views appears that they are stuck. This is a 3D image of the prosthesis. As you can see, severe mitral regurgitation and severe stenosis from the turbulent flow. This is a true view image of the same valve. And again, you can appreciate the turbulent inflow and the significant severe mitral regurgitation.
Tricuspid.
Tricuspid regurgitation. And the mean gradient here is 11. And you can see here that the pressures, this is underestimation because of basically equalization of pressure. And we see this all the time, triangular TR, tricuspid TR velocity. These are the two valves side by side, the mitral valve and the tricuspid prosthesis. And this is with color, you can see the severe TR and normal functioning mitral prosthesis. Thank you very much.
So it looks like the tricuspid valve is frozen. But why that is in just few years?
Patient is only 42 now,
Yeah.
so she had surgery in early 40s. We know that with bioprosthetic valve, the younger you are, because the body metabolism, the faster you degenerate. And remember, the tricuspid valve is a low flow state. So these bioprostheses, remember, they're originally designed for aortic and mitral position, and they extended to the tricuspid position. So we actually don't know, and this is actually not uncommon. We've seen most of the tricuspid valve reintervention for prosthesis failure are younger patients, like in this patient.
But what is the mechanism? What is the mechanism of failure? It cannot be degeneration.
Pannus, yeah,
okay.
basically, just thickening and these are processed tissue.
Also,
Yeah.
I think also Pannus.
It's a pannus formation
yeah,
causing the
pannus formation, yeah.
You can see the orifice very small, as Stan has shown nicely in the echo.
Yeah, the
image.
leaflets look almost like stuck
Yeah,
and
They're
very
stuck.
thick, very thick.
yeah.
Okay. So let's go back to our slide presentation. We continue. This is excellent things we have seen. These are our transesophageal pictures, which are 3D view of the tricuspid valve. Very nice. And then it is our CTA. Gilbert, you want to comment on it?
Yeah, so this is a St. Jude epic porcine valve. You can see that nicely shown there as the example. The fluoroscopic signature, you'll see it later, is not that visible. This is one of the valves that is hardest to deploy. The good thing about this particular case is that you see those very bright dots. Those are called core knots. And this particular case, because the patient, the surgeon decided rather than tying the knots directly with your fingers, they use the core knot, which increases the fluoroscopic signature of the sewing ring area. So it makes it a little easier to implant. And you can see the right side, that's the sapien-free ultra valve, and now we have residual tissue. And you can see that the valve size on average, mean diameter is on 25, area 470 millimeter square, and a perimeter around 77. So I think it's a nice 26 resilia. We can even add volume to post-dilate to make it better expanded, because you can see the pannus formation. So I think that will hopefully confer a good longevity with this particular device.
Beautiful.
And don't forget the leadless pacemaker there.
Yes.
And patient also had a leadless pacemaker we
Be
mentioned there.
careful with the-
So basically, this is a summary of the case. A severe bioprosthetic tricuspid valve stenosis and regurgitation from malcoaptation and pannus growth. And clearly that going for surgery will be very, very high risk. There's no true STS calculation for the tricuspid.
Correct. Not until just now. They just released the STS calculator for all operation. They just came out. So,
Just came out.
yeah.
Okay. So we just have to update our the STS risk for the tricuspid, which we don't have. But overall, it's a high risk third of surgery, and that's what we are going to plan in this particular case. Okay, Anu, tell us what you have done and where are we now?
So we can go on the fluoro.
Yep.
Exactly. Okay, hold on.
Deep
hold on.
probe up, please.
So yeah, this is a very nice
This
picture.
is the view where I
Very
will
nice.
be able to place the valve. If you see that.
And I'll just comment for those of you not familiar, those the things that's sticking out on the sewing ring of the epic valve, those are the core nuts. So you can see those little barb-like structures on floral, and that looks like a really nice way to visualize, quote unquote, the sewing ring of the tricuspid prosthesis and also the landing zone.
And those are the white dots we saw on the CAT scan?
Yes, that's correct.
Okay. Now, Anu will tell us step by step the strategy so that.
Pull back.
Yeah.
Dr. Sharma.
Right? Survive.
Yes.
Yes.
Hello, Dr. Sharma. So this Sapiens 3 Sapiens
No, can we go this way only?
device is this device the same as you used in the mitral valve
Can you
valve?
go J-wire.
That's correct. Yes, exactly. Same valve.
J-wire.
Yeah,
It's the
so
same.
yeah, exactly. And as you know, they have even done it in pulmonic
Edgeless.
positions as well.
Right.
So so all four valve position with the Sapien 3 platform is feasible.
Yeah.
So the same
Actually-
valve, same delivery system.
That is correct. Yes. Remember, just like the mitral, we need to flip the commander system upside down because the way the flex works. So it's basically the same as mitral, just you don't have to do a transeptal puncture.
Yep.
And Dr. Keeney and Dr. Kerr will actually show you how we approach this.
So
I
we're
think-
going up with the edgeless.
Yeah.
Okay.
So I think one of the
Let's see.
discussion for
Keep
tricuspid
going.
is that they used to actually position the stiff wire in the right pulmonary artery because they thought that it might be more, trackable. However, we find that it's very non-coaxial in terms of deployment. So now the practice has changed that we typically would place the stiff wire in the RV apex instead, just like the mitral, the LV apex, to make it more
Pull back.
coaxial
Okay.
to
Okay.
cross into
Wait.
the tricuspid valve and deployment.
Why you took it out?
And you also
Crossing
see
with the
that
multi.
here, we do not use pacing on the right side. So of course, on the left
we
side,
should have used
you need to
J-wire
pay rapid
itself.
pace to deploy the Sapien valve in the mitral position. But in tricuspid position, we have not needed to do any kind of pacing to optimize our landing.
So this is the edgeless sheath in the
Edgeless.
RA right now?
Yeah. 3D on. I think J-wire is better. Never give this one.
Now,
Let
keep
us say
telling us
J-wire.
what are you doing now, what wire
we
you're
are
using.
trying to, we should be using the J-wire. I'll change it to the J-wire.
Okay, get me a J-wire.
Okay.
Yeah,
So
usually
we are right. We need a 3D view. Stam.
Yes.
Okay. Echo.
You want echo?
Yeah.
so severely stenotic valves,
You can
stiff
zoom in, please. Zoom.
glide wire is good, but for
No, zoom in,
predominantly
yeah.
regurgitant valves, J-wire is better.
Good. You went in?
No. This side.
No, the atrium is very big.
Big.
Can we get another view?
The
It's a wrong
multi-purpose
view.
catheter through the edgeless?
Yes.
Yes. Same as TMVR except the transeptal.
Now T up there. I
T
think I
probe
don't
up
see it.
stem.
Be up.
Yes, please.
Up.
Yeah. So
More.
There.
Yeah. Up, yeah.
make it point the other way.
So you can see that you can have a nice on-force view of the tricuspid. So you can actually maybe use that gillis to point right at the center to try to cross as well. That's another way to do it rather than an RAO projection.
You're on the other. Totally wrong. See
Keep
that?
coming. Keep telling the beginning. Yeah.
Yeah. Okay.
So
Not
let me
a
ask
good
the
view.
China team here. There, do you see a lot of prosthetic tissue valve in China for tricuspid, or it's mostly mechanical that you use? Professor Pan?
No, in China, we seldom use the tissue valve in tricuspid. We seldom use.
No, please leave it.
It's all mechanical then.
Mhm.
Yeah.
Pull it down.
Yeah, actually, in the surgical literature, there's really no mortality difference whether you use tissue valve or mechanical valve in the tricuspid.
Yeah, that's
The only difference is that with tissue valve, your anticoagulation is based more on mitral rather than tricuspid in terms of iron out target. So it's not higher than what you have for mitral.
Yes.
Mhm.
Why don't you put a multi-purpose ahead?
No, we have.
we have.
Multi-purpose. Let's try to go multi-purpose through the tricuspid valve.
We are not. The thing is, not able to get the end on.
Sam, can you show us on 3D where we are?
Here, 3D.
Yeah.
Here. You are on the side. See,
Side.
on the side. Yeah.
Yeah.
Try it on false view. You can just point at the middle.
Oh, there. Yes.
Yeah, that's good.
Yes.
Yep. Yeah.
Up, down. Almost. Yeah. Can you take the picture? Please? Okay.
Right here.
Come.
Mm-hmm.
Come.
Yep.
No.
The side.
There's a crossing wire.
You can always go for V18. In all these tough cases, go with V18 will
No,
go.
I think we can use.
We have a
just,
crossing wire.
Yeah. You want on
Or
false view?
V18.
Yeah, go.
On false view, I think on LA over
Get a V18 wire.
here.
Yeah.
Just point
You
towards the middle of the
magnify
circle,
this, zoom.
and then you should be able to get it.
No, but
So they put the gillis right.
Pedro,
in the
you're
middle
saying
circle,
something?
rotating
yeah,
in
I think
middle.
the fluoroscopy is
Yeah,
not
right there,
giving us
right there. Oh, just rotate
the
this
right approach. The TE, the three-dimensional is better, huh?
So,
Yeah. Other way.
For
Other way.
coaxiality.
there you go,
Other way.
there you
Yeah.
go.
Other way. Yes.
There you go.
Yeah,
Go,
like that.
Go in.
Good,
Yeah,
good,
got
good.
it.
Yes,
Got it.
Very good.
Great.
No, Arvind.
Yes. Let me see it.
We are.
Okay, good.
We are. Oh,
Yeah. Beautiful.
Now, in this process, what will happen to this leadless pacemaker?
Just,
No,
It can
that's
come
what
out?
we were saying. You have to be very careful.
no, the pacemaker has been something. It should be
Yeah, it's been 2
in
years,
already.
2 years,
All
yeah.
right. Obviously, we have to be
You
careful
do
with the
now.
stiff
Okay,
wire.
Again.
so I should,
Okay.
should put a picture.
So now they have advanced
The J wire,
the
let's put a
multi-purpose over the
300
wire.
now. It's not
It's
300.
300. It's 300. Always
300?
use long. I always use long.
Okay. Now long pigtail.
Get me a long pigtail.
So the other thing that we've learned is that with
Okay.
stenotic tricuspid valve,
Watch the wire.
we used to say try to flow a swan and then the exchange it's too floppy. So with a gillis, you actually have a complete control on
Damien?
steering. And a lot of these right ventricles are very big and different in terms of orientation. So we actually find this to be very helpful in terms of crossing, especially in stenotic tricuspid valve. Because if it's purely regurgitant, I think it'll be easier. Give a big orifice, but you can see how small that opening is, as
the wire.
Stam has shown you on the TEE. So it makes it much more challenging.
Okay, what is the next step now?
Now we are
Pigtail.
going to go with the long pigtail and then change it to a safari, right?
Yes.
Okay. Gilbert, can you tell them the view? Why you think on first view helps us?
So this like kind of like the exact what Stam is showing you on echo. It's just the opposite. So with the prosthetic valve, if you have a circle, and in this case, you can show that you just point that gillis right in the middle. It's like throwing darts. You're waiting for the center, and usually it should work in your favor. And then once you cross, then you can go back to the RAO to make sure your trajectory is good.
Go ahead.
Why RAO did not help us in the beginning?
I think it's just the valve is very
Good point.
stenotic, so you're aiming,
Spin it.
and remember these atrium are massive. Look at the echo there,
Wait, let me
right? So
put
the
this
big
down.
atrium, you end up very hard to
Yes.
get to the middle.
Flex on.
And also remember, there's also severe TR, so right atrial pressure is very high. So you're actually fighting against the stenotic and regurgitant valve when you advance the wire. So it's not dissimilar to severe AS. You're going retrograde. That you have a small orifice and then you're fighting against a high velocity jet.
Are we in the
No.
apex of the RV?
Yes.
You were.
No, I'm asking Stam.
Let me see.
Yeah, the apex, the RV is not big. It's actually dilated, but it's actually not big. You can see that on fluoro very well as well.
Floor.
Yeah, I think you are, Dr. King.
Yeah, we are. Because you can see the micra there, right?
Yeah, so the
Could
micra is
be-
usually at the apex.
Yeah.
Okay.
So here we have to just be very careful because it's a stiff wire.
Not
Hopefully
stiff
we
enough.
should have enough support.
Wait. Let me come out with the.
Not yet. Okay. Let me remove the
So,
pigtail first. One
it should
second.
be
Can
together.
you put the full volume, please?
Cannot be.
So the other thing is that in China, you have the different transcatheter
But why?
native tricuspid valve replacement. At least
Spin
my
wire, okay,
understanding
spin
is
wire.
most of them still put the stip wire in the apex. Is that true, Professor
No,
Pan and the team?
We prefer the Safari.
Yes.
Good.
But
Yeah,
yeah,
yeah.
but you put the wire in the apex, right?
You're
I'll
good.
be
Did you
apex.
suture this?
No, you don't, because you'll pull it
Yeah,
back
apex.
No,
get the balloon inside the
It's
valve.
coming out. Hold the.
Let me hold this.
So here, the top of the Safari wire is in the RVOT.
Yes.
No, it's
No.
across the valve. You see the sewing ring is with this view is overlapping with the mechanical valve. But you see the
Valve.
wire is basically going from the IVC, you got wire, right atrium, crossing the valve into the RV apex. It's not RVOT. But used to place the wire in the right pulmonary artery for support, but we no longer do that because it's not as coaxial. And you see, once the sapien free valve is crossed to the tricuspid position, that it's like the mitral, that is more coaxial if you place the wire in the RV apex. But of course, you have to be careful in terms of risk of RV injury. That's why we use a Safari wire, and you have to be careful about
So the
getting the valve. So you have
skirt
to
is
check-
other way around.
Yeah, so skirt we check, make sure it's opposite, like the mitral is antegrade,
Yeah. Okay. So you're holding the wire.
Yeah. Plural.
and the commander system is upside down.
Good. And let's mag out.
Yes.
Is it upside down?
Yes, it is.
Good.
Yeah. Okay.
And no role
Mag out
for
more.
balloon
Yeah.
here, huh? No role
No.
for valvuloplasty here.
It's an open valve.
Yeah.
Beautiful.
Fixed open leaflets.
So we're gonna go so
Keep
that you
going
can
again.
see the sheath. Just like the mitral position, we sometimes have to pull back the sheath to be able to mount the valve onto the balloon.
Yep.
Keep going. Good. Keep going.
So Dr. Kinney is taking her time because you don't want to have changed the trajectory with the right ventricle. This is not the left ventricle, it's the right ventricle. So we're very particular about pushing too hard with the wire. And
Keep
she's nicely, you can see that advancing up through the sheath. And then once she's in the
So
position,
now
then she'll pull
I will
back
pull
the sheath
back.
to a little bit more. A little bit more.
Good.
Yeah, good. Okay.
Yeah, let me pull the sheet
Bring
back.
the
One
sheet
trick
back.
is don't suture these sheets because you
So
have to pull
Pawan,
them
come
back.
here.
Yeah, I don't worry.
Hold-
It's
Okay.
I
You're
can
all right.
help you. Good. Okay,
good.
let me mag in now.
Gilbert, come on my right side.
Okay.
Gilbert, come on my right
Yeah.
side.
Okay. Yeah, I got
Hold
it.
the
Alright.
sheet. Press. It's bleeding.
Yep.
Push the wire, Gilbert.
Yeah.
Okay.
So I'm gently applying forward tension on the wire, so you maintain that trajectory. While
Okay,
Sahil
good.
lowers the valve, you can see that onto the balloon. Okay, and then now let me center the screen, please. Okay, so I'm just
There's
gonna,
no rush here.
no rush here, exactly.
Go
Good.
ahead. Yeah, go ahead. Go ahead.
Fully flex.
So-
Fully flex.
Yeah, it will. As you approach.
Fully flex.
Yeah.
So I'm just maintaining neutral tension on the wire so you can easily cross. Remember, this is the right side, not the left side.
Perfect. Little more. Little more.
Okay. Good.
Okay, good. Let's go to view now. 1 second, please.
Now can we just adjust?
Sorry.
Pull the
Yeah.
thing back.
So which view was that? 15.
52, 15.
Okay, so we're going to be very steep, huh?
Yeah.
Okay. Okay, anesthesia team, just beware of the patient ahead, please.
Stam, how
Hold
do
on.
you
Hold on. What's
Yeah.
that? Broken
This is it.
connection.
Yes, sir.
how do you see it at the,
Actually very
the
good.
plane of the valve? How do you, see the
you see
prosthetic
this
valve?
core knot that I mentioned before? And so if you do a Sinai, you also see that as well
Yeah,
very
yeah.
nicely.
Hold the wire.
It's very
Push the
coaxial.
wire.
Very coaxial.
Yeah, push the
Yeah,
wire.
very
Push the wire.
ventricular. Yeah, that's right.
So everything has to be slow here.
Isn't it,
Yeah.
isn't it a little bit too far in? Or
Yeah,
Yeah,
we're
it's,
going to pull
it's
back.
too
We're going to pull
ventricular,
back.
yes. So we hold on 1 second. We go to, yeah, there we
Yeah.
go.
that's better.
Yeah.
Yeah.
Okay.
So we can just Sinai test because
Yeah.
there's
But
no pacing
don't
here.
do 3D. Show us 2D. Okay.
2D.
3D is
Okay.
good.
Good. Good.
Looks
So
very
everyone see that how we position here, similar to And then it's a very slow inflation because obviously we're not pacing.
And it's going to obstruct the mitral or disturb the physiology of the mitral valve at all?
No, it's way far.
Okay. Do a
Ready?
Sinai. Yeah.
So Sinai deployment. Huh?
Sinai deployment.
Yeah.
Everybody is in a good position.
Yeah.
Yeah, good position. Yeah, one minute. Let me see.
Yeah. Show me 2D so I know I
Yes.
confirm.
2D, Dr. Kinney.
Okay.
Where? Okay.
Going very slow.
Okay, ready. Okay, go. Start going. Inflate.
Yeah.
Slow inflation.
Very nice.
Go full.
Sinai.
Go.
Full. Yeah.
Excellent. Fantastic.
You have to do one more.
Slowly pull back.
Yeah.
Okay.
No, why don't we
Good.
do one more?
Okay, go
Everything
in.
is looking good.
Go in.
The one.
Okay. Going up.
So resilia is a very stiff tissue, so
Go in a
we
little
usually
bit
do a
again. Go in a little bit.
Go
two
full.
balloon dilatation
Oh, go in. Okay, yeah, good.
to expand it further. All
Go,
right.
full.
Pull.
Full?
Pull.
You see it in
Nothing
the T2.
Yeah.
Okay.
Yeah.
Should we
Yeah.
put another CC?
Let's see how it looks.
Okay, coming out.
Okay.
Tell us, do we need to put another CC
All
and
right.
inflate?
Let's assess on echo.
Yeah.
Yeah.
Beautiful.
Okay, coming out.
So one thing is
Beautiful.
important to note here, even though the measure CT diameter is 25, remember you have pannus tissue, you have other things. So that's how you see a waste there.
Yes.
So some people even argue you should fracture these, right? This is a fracturable valve. But I think for the purpose of this case, we'll not fracture. And we have not done any mitral fracture, but there's some people who have started considering that in terms of risk of mismatch and underexpansion. No. But I think this is a beautiful result of exactly where you wanted to land in this, and you see that it does not require pacing, just a slow inflation.
Yeah.
Mean gradient of 2,
Fantastic.
minimal central MR, no PVL. Actually, the MR left. No,
TR.
Sorry, no TR at all. No
Good.
PVL.
Beautiful.
Mean gradient of 2.
Wow. No TR at all.
No
Good.
TR, nothing. No, it went away. It was a little bit in the
But
beginning,
you
but
think now that there's a valve, we go one more CC and go?
the leaflets got.
I mean,
used.
you already nicely flare
flared
outward,
out
so
nicely
you're just
here.
constrained at the sewing portion of the tricuspid, so I wouldn't necessarily do that.
I think it's a very stable position.
It's a stable
You have
position.
good
It's
flaring on either
right-sided.
sides.
Any comments, Professor Pan and your team?
Yes, this is a very beautiful procedure. So our question is, why not use pacing in the tricuspid position?
Well, it's a right-sided system, so it's low pressure. So the other question is that where do you put your pacing lead?
Yeah.
So the only option would be either left ventricular pacing or
RH.
coronary sinus pacing. So those are the only two options. Of course,
No,
you can
even
also
coronary-
have a program, someone there to program the micro to do rapid pacing. So it's more complicated than necessary. We learned that through lots of tricuspid intervention with replacement, in terms of some of the vivid registry and others, that the practice now is no pacing is necessary for the right side. And our congenital colleagues do intervention on the right side a lot, and they don't usually do pacing at all.
No, even if you do coronary sinus, it has to go through the
Correct.
temporary.
So
yes.
typically you would have to do it in the right internal right jugular vein access to do pacing on the right side, or left ventricular pacing with a stiff wire on the left side. So again, it adds to the complexity of the procedure. This is, in our mind, probably the simplest, at least from the AV valve intervention that you can do in terms of replacement.
So everyone
And-
believes
and-
no need for one more CC?
Think everyone agrees?
And patient is
and then-
quite young. If you any
Yes.
gradient,
No,
You
it's
think
two.
It's two.
2. Gradient is 2, Dr. Sharma.
No, that's the thing.
No MR, no TR, no PVL.
Good.
Perfect. Perfect.
If
then
the other
you
comment
can-
will be if the pacer is going through the tricuspid valve during the deployment of the valve, then the pacer will be in between. Yeah.
Correct.
Yes,
yeah. So
yes,
so
yes,
that's why you
yes.
cannot put anything
You
in
cannot
across.
do it. Yeah. Exactly.
Okay.
Okay.
Now come out.
I mean, if you want, we can do a pullback, but I think I would exchange with JY.
No,
JY
no,
with
no.
the
I'm
pigtail.
only concerned is another CC there because she's a young patient, cannot have anything.
let's add another
anymore.
CC.
Right.
Yeah, I think Dr.
Last.
Kinney's concern is valve deformation because of the waist, which is because of the pannus. So we're going to do one more inflation with one more CC.
They will become 27.
So around 27.
Gilbert, you okay?
Yeah. So hold. Let me position the wire. Can you advance, please?
Go ahead. Go ahead. Slow.
So the balloon is not fully deflated. Right? You see that, right? Just make sure it doesn't get
Yes,
catch.
fully deflated.
Yeah, now it is deflated.
Sorry.
Yeah,
Sorry.
good,
Okay.
good,
Little more. Good.
good. Okay.
Okay. Okay, going up.
Sinai.
All right. Okay.
Okay. I think we are good now.
Okay, so you saw that
It
it
flares
is
out.
more expanded, more flared. The waist is
Better.
less than before.
Gradient lower. You want to put a what pigtail?
Pigtail, yeah.
Yeah.
Let's do some hemodynamics.
There's a gradient. Yeah.
Leave it.
You hold the sheath, please.
Yes, yes, I am.
Push the
Oh,
wire.
wire.
That's
Don't worry.
okay.
Don't worry.
Right, right.
You got wire? Yes.
Yep.
All right.
Pigtail is.
So it was a 2 millimeter gradient last time. I mean, it will be very tough to see even less than that, the echo.
Yeah, 2.
Yeah, I mean, in the future, when if the valve degenerates, I think this is kind of a bridge to the next surgery. This patient's only 42, so we don't expect this valve to last, 20 years, but maybe hopefully 10 to 15 if we're good. Although the last valve only lasted 3 years,
Yep.
2 years.
3 years.
So
only.
we have to be very careful about the the follow-up on the echo and function.
Dr. Tang.
Yes.
Yeah. So right now the gradient is 2. So
Yep.
what is the perfect gradient you think in the tricuspid valve, the cutoff point?
Great question. So
Yeah.
as you know, in Triluminate trial, we're doing the transcatheter edge repair with TriClip. And so those gradient, we found that as long as 3 or less, that should be fine in terms of at least for the edge. So I would imagine for prosthetic valve will be similar. Stan, what do you think? You're
Yeah.
part of the Triluminate trial.
Yeah,
so-
around 3 to 4,
What
3
is
to
it?
4 at max.
Yeah,
At max.
yeah. Especially
connect
remember,
here?
once they exercise, it can increase as well.
This
So
is
we
in
have to
the
be aware,
IDC.
be mindful of that.
That's
So-
okay. Just checking gradient.
Thank you.
And
Okay.
Gilbert, are there any data that is associated with better or worse outcomes regarding procedural, residual or in tricuspid?
Great question. So I think there's still very few patients with elevated gradient after tricuspid intervention, especially repair. So the Triluminate trial did have some patients with a gradient 4 above,
Put a pigtail
and
side
they
by side.
but there are very few of those patients, and it's too early to tell whether they have any
Can you-
adverse events. But certainly, I think
Get
from
me
the
a picture.
tricuspid standpoint, obviously lower
No.
gradient the better,
You don't see?
because it's a very dynamic
What
system.
color is the other one?
So that's why I think I agree with Stan that around 3 would be probably the cutoff that I would be able to would tolerate for intervention.
And no values for hemodynamics like RVEDP here?
Sure,
You just do
sure.
every-
Yeah. I mean, but keep in mind that we only have one single access. We would have to
No,
put
we
an
are- we
internal
are to-
jugular line or some other line to have a measure the right atrial and right ventricular pressure.
Cool, eh?
Of course, you can also still do a right high calf after this if you will want to, to interrogate the right heart more further. So,
Yeah,
but I'm not sure if we need to in this particular
Yeah.
case. The RV function appear normal. It's dilated. The right atrium is massive, as you see on the echo. So again, the right atrial compliance is going to be very, very, very different, from a normal right atrium.
And what is the pulmonary pressure that we are seeing right now?
Well, we don't have a
don't
PA
have- we don't
catheter
have
in
a
there.
I'm sorry,
Right.
RV systolic pressure. I apologize. RV systolic pressure.
Well, let's maybe show. You can see
52.
that here.
52.
that? 52,
Okay.
yeah.
Okay.
This
Yeah.
is in the RA.
So we're doing an RA-RV hemodynamics.
Now, one thing, that's a very good question, Dr. Moreno and Professor Pan's team. These patients, you have to make sure the right ventricle is not too sick.
Yeah.
Because if
Exactly.
they're very sick, you now have an acute loading of the right ventricle now because you don't have the stenosis anymore of the tricuspid valve. So you have to alert with the anesthesiologist to make sure you don't have an acute RV failure, as you mentioned. So you're absolutely right. This patient has a good right ventricular pressure, but your patient with very low right ventricular systolic pressure, you worry about burnout right ventricle and can actually go into acute RV failure if you intervene in this procedure. So that's something that from a post-op management standpoint is very important in patient with a very sick right ventricle. But great point.
And this,
Can you do fast speed? So about 2 we are getting, no?
Yeah.
16 and 14. 16, you see that?
So you see
13,
some
16, yeah.
right-sided pressure measurements here?
16 RV
And
RA
14.
pressure. Huh?
Yeah.
And
That's,
14.
there are signs of heart failure, of right ventricular dysfunction here.
Yes.
But certainly, with the experience of you guys in the OR, having had post-operative massive RV failure, how do you extrapolate this? This is a specific question. Any contraindications to do this procedure in or very high risk for, let's say, RV systolic pressures?
I mean, extreme pulmonary hypertension, Dr. Sharma, Dr. Kinney, any thoughts on this? I mean, I think if you have like an Eisenmenger's kind of adult congenital situation, that's what we worry about that.
There is a way to figure this out by the RV to PA coupling.
Yeah.
Yes.
Or you evaluate with TAPSI and PA pressures. You can see, if the ventricle can withstand, if the ventricle is too far out, too far worse than what you expect. And this case, actually, we did not measure, but doesn't look like it because the RV looks functioning well, and the PA pressure that I get now after the new valve is about 25 plus 15, so it's about 40 systolic PA pressure that I get now.
I think it's similar to any tricuspid therapy, RV to PA coupling, and RV systolic pressure that is high is a good sign that you have pulsatility in the RV.
Yeah,
so any tricuspid device you do, doesn't matter whether it's TTVR or Intrepid or any of the other replacement or repair strategies, you need to have RV pulsatility.
Yeah, absolutely. And to Dr. Moreno's point about the operating room, the difference with this is that there's no heart-lung machine.
Exactly.
So the cardiopulmonary bypass impact on the right ventricle is not trivial, especially if the cross clamp the heart. So I think that is what we need to, as a surgeon, we always want to protect the right heart, not just the left heart, because that is what will get you out of the operating room successfully.
Excellent
now
comment.
you're going to remove the sheath. What is the next purpose? And you're going to put a closure device? What are you going to
just one ProGlide and we're done. Yeah.
Do you need a wire
Nothing,
or
yeah.
just take it off? So we just
Some
take the
micro there.
pigtail from across and then we'll close it. Yeah.
Done. So nothing to micro, it's pretty safe. Done.
Yep.
Document that, please. Document the micro is okay.
Yeah. T, please, Stan.
Sorry? Yeah. You going to pull out the D?
Yeah, no, just pull it up, just so we can show both valves. You can see nice on force.
Pull the T up. Okay, now
Smiling
good.
face.
Yeah.
There you go.
Two valve, the pacemaker and TE, four things in one.
Okay.
Okay, good. And then take a RAO view for the micro.
And patient has the constrictive pericarditis also. Look at the calcific pericardium.
And then we can show the.
Okay, this way. Yeah. Take another cine. So our EP friends will be okay.
Okay. So you see everyone, all three valves, two valves and the micro again?
Yeah.
Okay, good. Excellent. Okay.
Okay. So now with the procedure, actual procedure done, let's talk about some tricuspid points. We can go back to our slide presentation. There are any questions now from Pedro or from our Chinese colleagues?
I don't
see
see
the procedure
any
point of view. Okay.
from the audience. We don't have any questions from the audience. No.
Okay.
Oh,
Understood.
Dr. Sharma.
Yeah. Yes.
Hello, Dr. Sharma.
Yep.
Yeah, so I have a question for the anesthesiologist. So during the procedure, so what kind of medicine he used to maintain the hemodynamic stability?
Dr. Stone.
Yeah. What medication are you on, and what's your strategy in terms of managing the right ventricle during these procedures?
Phenylephrine is the answer, huh?
Yep.
In case you get hypotensive, yeah.
Yeah. So so Dr. Stone, our excellent cardiac anesthesiologist, said phenylephrine as a start if the right ventricle is okay, but if it's struggling, we might have nitric oxide. That's also a adjunct invasively.
Yep. All right. So just some theoretical discussion on the tricuspid valve. And this year, there have been a lot of publications, and I'm going to talk about this one by one. One is the Triluminate pivotal randomized clinical trial, Sinai being a main center, and Dr. Adams, one of the PI. I mean, he's the PI with Paul Sorja, co-PI, and then Bright study registry, basically Triluminate in all type of cases with a 30-day outcome. Triluminate is 1 year outcome. Then the clasp. So basically another device rather than TriClip at 1 year, and then the replacement of the valve, the 1 year outcome, and Evoke registry, 2 year outcomes, then TriFlow device for TR, there's another fancy, just presented, one case done, and the concomitant TR for secondary tricuspid regurgitation and MR. So this is actually the very common picture, all we can use the devices at various levels. What has really gone further is cooptation devices and now the transcatheter valve replacement and TTVR. And that's exactly what we did today with this patient. So first is the Triluminate pivotal trial presented in ACC and published in NEJM. It's a much more addition, I would say, improvement on the already existing mitral clip. So TriClip G4 delivery system, and I think in China they said they have only G3. So what is the difference, Gilbert, and G4 and G3?
So G3 has only two sizes. The narrower clip you can see on this picture, the XT and the NT. And G4 now has 4 sizes, but also allows you to independently grasp the leaflets to optimize the repair and customize. And with the TriClip system, you see the knob has changed as well. So it's not like the MitraClip system. So it makes it easier to steer down and more coaxial to the tricuspid valve.
Okay, beautiful. So basically, this was the single arm. The registry data were presented of 80 cases and so, but the randomized was about 350 patients to TriClip and medical therapy after very intense eligibility committee evaluation. So we actually present 5 cases, maybe 2 or 3 makes it and others are excluded for various reasons. And clearly it has to be the ability that all the parameters are that investigator feels that they are going to reduce the TR to moderate or less.
Yeah,
right?
for the randomization.
Randomization. And we have the 1 year follow-up, and these are the cases basically overall large, almost everyone is the severe, torrential or massive. So very, and of course comorbid conditions, and these were the primary endpoint. And they basically were composure of death or tricuspid valve surgery, heart failure, hospitalization, and improvement of more than 15 point of KCCQ score. And basically in the device versus control was superior, and others were secondary endpoint, which are shown subsequently. So basically what is shown is that the decrease in the TR severity, as you can see there, in the trace to mild to moderate or severe, the red group, which is on the left side, and in the follow-up at 30 days and then 1 year, you can see the red in the device group significantly disappears. About 10-11% remain the severe, and so others become mild to moderate. And this is the important, this basically what led to the positive endpoint of the trial. And you see there was no difference in the death or surgery and heart failure hospitalization, but KCCQ change more than 15 points was much higher in the tricuspid TriClip group versus the control. And basically overall outcomes were similar. And so also shown that quality of life parameters, that if you're moderate or less versus severe, increase in KCC score actually happens higher when you started with the more significant at the residual tricuspid regurgitation. So I mean, you same basically that you leave more residual tricuspid regurgitation, less will be your improvement and patient's feeling. Other endpoints are very simple, safety profile very good, and they actually have put together all the tricuspid valve trials, and where the triluminate comes in very nicely in terms of 1 year mortality of about 7%, and the rest actually all based on the various subgroups and concomitant baseline risk factors. We have in some of the trials of the tricuspid, there is up to 20 to 50% even mortality. So overall, did very well from all point of view, and of course, from quality of life improvement point of view, also very good in the middle, as has been shown. So this basically was that this is the first of the trial, which of the randomized tricuspid trial, which shown quite good in terms of improvement in quality of life. Although a lot of people were concerned that the really quality of life is one, but we need to say some hard data. And hard data basically in these patients is repeat hospitalization, but that was not noted. Gilbert, do you want to comment on that important point?
Yeah, I think that this is a 1 year data, so it's early. I think we know that from even surgical literature and medical literature that people don't die of tricuspid disease in 1 year. It's about 2 to 5 years that people start to have a high mortality. So I think we'll see how the 2-year follow-up will be. Hospitalization is interesting. It could be due to multiple factors. This is a heterogeneous patient population. We see it all the time. We see patients with MRTL or isolated TL. They're two different patients, but they both got, obviously, the MR being treated enrolled in this trial. So we have to do more subgroup analysis.
And very important, because as said, the tricuspid people don't die. There were those who were enrolled in this 7% mortality at 1 year. And remember, in our tower trial, the 1 year mortality 30% or 20% in the intermediate group. Then in your mitral clip, about 17%. So clearly, it's a lower group. And very nice, editorial and actually conclusion of that the tricuspid tier is safe. And so then what about patients? So you take, this is the BRIGHT the registry where all cases, so not necessarily very strict based on the triluminate, but as the kind of real world data of the tricuspid G4 tier system for multiple centers, including USA and Europe, and same, the latest device was used. All these are high risk patients, severe, and actually look now. The implant success 99%, procedural success 91, device time 76, and total procedure time 96. And number of clips about 2, and various clips here. So Gilbert, you want to comment on this one compared to what we do in our real life versus what was noted in the triluminate?
Well, this is European data, right? Because in Europe, they have commercially available tri-clip system is CE marked already. So this is the registry from our European colleagues looking at the early experience of the G4 system, a dedicated system in this. And you can see that, just as MitraClip, the procedure is very safe. In experienced hands, these are experienced center, you can see the procedure time is reasonable. And most of the time now, they're using the longer clips and the wider clips because they find a better TR reduction and easier to grasp.
Yep, and great success, close to 100%. And of course, reduction in the TR, this was a 30-year data, very significant, as well as improvement, and see the complications, just a very, very minimal, very low complications of the device. And for same, functional class, KCCQ improvement, and so clearly showed that even real world, very safe and effective in treating tricuspid regurgitation. So now if you put together, and this was the editorial by Orman and Masberg of the NEJM of the triluminate, there are 2 other trials going on, which is the TRI-Chi-F and TRI-FR with the various types of regurgitation, will give us the overall data in terms of where the tricuspid clip should settle in. But clearly the first pivotal trial is very positive, and I was told that they are going to go to FDA with the we are part of the triluminate, and now we have a continuous access for the patients who are appropriate, they're getting the clip, no longer randomization while waiting for the FDA panel. What is the timeline, Gilbert, in the FDA panel?
I think probably the commercialization here in FDA approval, hopefully early next year. That's our goal. But the good news is that with our continuing access, we've seen an increase of patients with TR referring to our program, and they are all very happy about the results that they get, with the TR reduction and actually symptomatic improvement. I think that is a win for the patients.
Beautiful. So then, so second is the Kodali presented and then published in a 1-year outcome of the Pascal device, the similar way, Pascal and Pascal Ace implant. The data are similar to what we have, the same, it's the edge-to-edge repair. And overall, of course, it just depends on your experience. And I know the Pascal 2 and CLASP, the trial 2D, has compared both devices in the mitral side, but tricuspid also similar type of data that is just with the gradual experience, although we do not have at Sinai. Is it clinically approved for right side? No.
No. That's right. It's
not
still
nothing.
completed
So,
trial.
yeah, and so probably the trials is still ongoing for the tricuspid valve point of view. Good success rate and overall same. The timing and the complication rates are very small as shown here using the 30-day and 1-year outcome. So class TR. So now we got 2 of them. And clearly more important is heart failure hospitalization was significantly reduced in these patients, but they're only controlled to themselves. So this is the Pascal system. So therefore another device. So clearly we got TriClip. Now we got the Pascal for treating this tricuspid regurgitation. Then you go to the next level, the replacing the tricuspid valve with the complete replacement with the Evoque system. And initial 30-day data were originally presented, and now the 1-year data were presented. The TR severity, as you can see here, remains mild, or maybe the TR grade 2, or in 96% of cases, it's less than 2. So just to say that whatever is done with replacing the valve, it benefit continues, and same way the functional class improvement. So this is the central figure. You can see here, this is the 27 patients. Initial data were presented first, and now they have the 1-year data overall, but works quite well, and reduce the TR significantly over 96%, and benefit continues with a very low mortality of about 7% hospitalization and so. So these are basically the overall various aspect of improvement. And key is that there is almost no mortality. So only because patients are sick, they have, and all the RV dimensions and functions all changes. So clearly Evoque is the device. The trials have been still ongoing for that, and basically where it will fall in, we need to see, maybe we'll take another 1 to 1.5 years. Now there is another center, I mean from Europe, they have the data on 38 patients up to 2 years. Overall very nice, same way, what were the data for 30 days and 1 year. From United States, basically there was 1 migration, 3 patients require pacemaker, so 38 of 3, like 6-7%, and then 9 cases of halt. So it's not uncommon. All of these patients are on anticoagulation. The 2 valve thrombosis and halt is very common. I mean, 9 cases of 38 will really make a very high incidence of halt in these cases. Gilbert, you want to comment on, despite almost everybody is on some kind of anticoagulation?
Yeah, I think that is going to be potential Achilles heel TT valve. So here you want to comment about, the whole replacement. You're the PI for the trick valve, right? So in Sinai. So
yeah, no, I think it's a very important point that Dr. Sharma made here, that thrombosis is a real problem in valve replacement. And with clipping, you have an issue with leads or malcoaptation. So a lot of these patients with who are referred for TR are candidates for neither of these procedures, whether it's replacement or for clipping. So we do have trick valve here, which is IVC, SVC, dedicated valve system. Again, right now it's a palliative procedure, if you will, who are not candidates for either of these strategies. But again, we have to think about pre-existing leads, risk of thrombosis when we are thinking about valve replacement, and severe malcoaptation gaps, and leads impingement in clipping. So there's going to be a patient who fits none of these devices. And that's why it's so hard to select patients in these cases and where to fit them in.
So another device, so this one which we had to continue to follow, and TTVR, Evoke, very promising. And so they put it together as an editorial, that effective device and low heart failure and so. Now there's a new device. They actually presented one case, TriFlow, and try to understand a little more is the tricuspid valve flow optimizer, and patients with the tricuspid regurgitation, some like a tripod, putting percutaneously, and they say basically decreasing the restriction of the leaflet cooptation and decreasing the regurgitation from 5+ to maybe 3+. Gilbert, any comment on this? Because there's very little data available.
Yeah,
They did
I
one
think,
case.
you know, Edwards used to have the spacer that tried to kind of, you know, improve the TR by doing that, but this is actually has a little valve that actually maintains the flow through the orifice. So I have to see, I think, you know, the question is whether the anchor stability and with time, you know, so we have to, you know, look at longer follow-up in terms of the durability.
So they did a one case and now they say we're starting the trial. So other question very commonly comes, this is the last of my presentation, is that patients have, many of them, severe MR and severe TR. And of course, it's already secondary, TR is the most common mechanism. So should both be combined? Should you do a concomitant, the tier of the mitral as well as the tricuspid? And they actually have a very nice algorithm. So where you should use isolated tier and where you should do a concomitant strategy. Basically, if you have a pre and post capillary pulmonary hypertension, that is the case you basically do the tier. And or if you just have a only isolated even capillary, you know, high wedge pressure, basically, that those cases you do a tier and wait, and how they're going to improve. But if there's no pulmonary hypertension, those cases may require the tricuspid clip also at the same time, and the RVPA coupling, those are cases will require the simultaneous the tricuspid clip. So what is our experience here of the mitral clip and tricuspid?
Well, I mean, we don't do them concomitantly. We do them staged because we have triluminate as an option. So we typically, per the study protocol, we do the mitral first. Then we wait 60 days to repeat the studies, and then if they qualify, then we just put them into triluminate. That's been our strategy. And also remember, tricuspid is not that straightforward in terms of a clipping standpoint. There's imaging issue, there's a device issue in terms of steering. So these procedures can be long. So our mitral clip cases are very short, 10 to 20 minutes, depending on number of clips. Yesterday we did one with only 7 minutes with 2 clips. So we like to do mitral first, and then plan for the tricuspid.
Okay, Anu, you want to comment on the quickness of doing the mitral clip versus tricuspid clip?
I think the imaging is the key. With the mitral, we have the imaging is way better. So our tricuspid you cannot, and sometimes we have used even ice. So that is why tricuspid probably takes a longer time. Always there is a learning curve. So I think we are still in that learning phase. That is why it's taking a longer time. But I think like discussion has happened and Gilbert mentioned, always do the tricuspid and wait and see. And most often, mitral first, wait and see how the tricuspid will respond rather than do at the same time. Yes.
So in, let's say, last 3 years, how many cases we had done mitral first and then we brought the patient back for tri-clip?
I would say about, close to 10 now.
10.
Yeah, that's just suddenly actually an increase. Last, 2 weeks, we have like 4 or 5 of them. We did the mitral, and all of them have severe TR that is going to be screened for triluminate.
And that actually, they have the whole algorithm using the pulmonary hypertension, whether you combine, and what has shown, and this is a very important slide, that these cases, if you do only isolated MR, you see the mortality is 33%, but if you do concomitant both MR and TR, whether it's same sitting or stage, really goes down to half. So this is the interesting that once you do MR and TR case, after MR, don't leave the patient cold, means follow it, and if continues the TR, then you should take care of that. So this basically they have pro and con, and the whole algorithm very nicely. It basically goes down to the same, that if you have coupling or you have isolated post-capillary pulmonary hypertension, that means high wedge pressure. Yes, those cases you do both combined versus TR only. So nice algorithm for that. So just complete it now. We are reaching to the time. TriClip device is safe and effective treatment strategy in selected patients with TR with significant improvement of KCCQ and quality of life indicator, but no impact on MACE or repeat hospitalization. Then Pascal device has also been valuable addition to tricuspid H2 has repair and good data up to 1 to 2 years. Then TTVR using Evoke system shows excellent short and long-term results with a reduction in TR, but with some low incidence of device thrombosis despite use of oral anticoagulation. And many patients with severe MR also have severe TR, usually secondary, and may require combined TR procedure, especially in patients with low pulmonary pressures and RBPA coupling. This combined or stage double valve TR strategy associated with improved survival compared to MTR alone. So there is now 3 questions. Following statements are correct for 1-year outcomes of the trial-luminate pivotal trial of severe TR, except higher quality of life improvement in the TriClip, similar MACE rates between both groups, similar mortality rates between both groups, and reduced heart failure readmission in the TriClip group versus control. We know that there was no decrease heart failure admission, so it's wrong. Then following statements are true regarding the Evoke TTVR trial, except significant reduction in TR up to 1 year, significant reduction in heart failure class up to 1 year, residual TR is more than 2 grade at 1 year in 25 to 30% of cases, and halt is noted in about 10 to 15% of patients. Clearly, we know the residual MR is like 10 to 10%, more than 2 in after the Evoke. And then lastly, that following statement is false about the concomitant tricuspid valve TR versus mitral valve TR. Then concomitantly, combined TR has improved survival, usually indicated combined pre and post capillary pulmonary hypertension, useful in cases with RVPA coupling, and can be staged after MTR is isolated post capillary pulmonary hypertension after seeing the response. Clearly, that this patient is they're not good where there is pre and post capillary pulmonary hypertension. With that note, we complete our presentation for today. And if any questions from our Chinese colleague, and Pedro, you make the conclusion.
Very good. Well, thank you so much for joining us from all over the world. Thank you for the heart team, for the structural team at Cath Lab at Mount Sinai. And thank you for Professor Sean Bean for being co-moderator since from China. Remember, this case will be available this afternoon in ccclifecases.org. Most importantly, we do our Heart Lives cases every other month, the second Tuesday of the month. So today is August. We're going to do it in October 10 at 9 in the morning. Thank you very much.
Okay, huh?
December symposium.
Yeah. Yep. So that will be later. Okay, done.